Good evening to all the participants and welcome to this session of COVID webinar brought to you by Mitra Company. I am your host for the evening. I am Dr. Sharbhanu Ghosh. I am the Customer Relations Manager from Mitra. And on behalf of the company, I welcome you today on this particular webinar, which is titled on the relevance of antibody testing for COVID-19. And to make it more relevant enough, we do have two eminent speakers today for this particular event. We do have Dr. Neeraj Jain. Good afternoon, Dr. Jain. It's a pleasure having you on board today. And we also have Dr. Shukla Das. Madam, it's really a privilege to have you today. So,
thank you.
To all the participants, as we have been doing it before, this particular webinar will be of scientific origin, and we will be dealing with the nuances of all the COVID pandemic. And both our esteemed speaker will actually teach us and enlighten us on the relevance of antibody testing. We will start off with the presentation of Dr. Shukla, followed by the presentation of Dr. Neeraj Jain. And at the end of this particular presentations, we would have 10 minutes of question and answer. So please feel free to put your questions in the chat box, and we will definitely try to take as much as we can at the end of the scientific session. Furthermore, we would welcome to have suggestions also. So please feel free to put your suggestions also, and we will try to improvise in our forthcoming some webinars also. Before wasting any more time, a quick introduction of our speakers. Dr. Neeraj Jain is a MD pathologist and is a doctor of immense repute. He is the president and course director for Mila and is a senior pathologist in West Delhi. And he has completed his graduation and post-graduation from University College of Medical Sciences in New Delhi and has been the secretary of Association of Practicing Pathologists. He has more than 2 decades of experience in various institutions all across the country, like from AIIMS, PGI Chandigarh, PGMS Rohtak, Ahmedabad, and has been the member of Governing Council of Association of Indian Laboratories. And he has been an NABL assessor and has trained many people in ISO and NABL accreditations. And he holds green belts in Six Sigma Lean Concept in Indian Statistical Institute. And he has been constantly awarded by Indian Medical Association also. And recently he has been also awarded by the Medgate Award for Best Institution for Health Education. Dr. Shukla is the director and professor at the University College of Medical Sciences at Guru Tegh Bahadur Hospital, New Delhi, with more than 2 decades of service. And her areas of interest includes immunology and autoimmune skin diseases, allergic fungal infections, and dermatophytic infections. She has been awarded with the Saudi and Silgupta Memorial Award and the Best Publication in Satish Chandra Memorial Award also. And she is a qualified Lean Sigma Green Belt trainer also. I would really welcome both the speakers today to begin with. So, ma'am, I have enabled the share screen. So it will be you who will be starting first. So please feel free to start the session.
Thank you so much. Good evening, everyone. And I thank the organizers for giving me this invite today. Can you see the screen?
Yes, ma'am.
Yes, we can see the screen.
Yeah, thank you so much. So, yeah. So I'm grateful to the organizers for giving me this invite, and we'll be sharing some literature on this very important topic, that is relevance of antibody testing. And this probably, as we understand, as it has been predicted, that the third wave is inevitable, as we are reading in the newspapers and by claims that are being made. So serology is going to be one of the most important diagnostic tools, not only to understand the disease progression, but also to understand the immune responses in the vaccinated and non-vaccinated population. So that is why today's topic is all based upon the literature that has been cited, and we will try to understand what is this antibody that are being developed. Are they being of any relevance for identification, for diagnosis, or they are enough to build up the immunity in the population. So to begin with, I will just briefly tell you the responses. The immune responses are basically towards the coronavirus that we are talking about, COVID-2, which is a beta coronavirus, and it is a phospholipid. It has a phospholipid bilayer, enveloped single-stranded 32 kilobase pair RNA virus, and it is a complex of protein which has M, N, S protein, etc. So this, what we are understanding is that the most important target of the antigen that we need to understand is the S protein, which is utilizing its properties to enter into the ACE2 receptor. Now, here we need to understand that unlike the MERS-CoV and the SARS-CoV, the previous ones, here in COVID-2, both the symptomatics and asymptomatics have been causing infection. Whereas in the previous ones, the MERS and all, they were only the symptomatic. So you understand the transmission has been, we are unable to locate those asymptomatics. So the transmissibility has been more in this situation. Then the second point that we need to understand, are we looking at the population immunity? So yes, today's talk is all about how do we build up this population immunity so that we are able to remove this virus, or at least make it endemic, so that we are able to tackle with it, even if it comes at the with seasonal preponderance, or just comes in 2 seasons or whatever, just like an influenza virus. So with that, to understand the transmission, the epidemiologist categorized it as, we all remember the factor R0. Now here we need to understand the R0. If it is more than 1, there is exaggerated transmission. So what is the epidemiologists and the scientists are working upon is to reduce the R0 to less than 1, so that the transmissibility is reduced and we are able to gain the population immunity. And the best strategy probably at this moment is, with the 1.5 years, with millions of deaths, with corona pandemic, is immunization or vaccination. A little bit of the pathogenesis is very important to understand, that it undergoes the RBD. The RBD is the receptor binding protein of the S. S protein is the most important surface protein, which is a trimeric molecule. It has an S1, S2. S2 is the fusion protein, and the receptor binding protein has a very high affinity for ACE2 receptor. Unlike the MERS-CoV, which were actually attacking the dipeptide peptidases. So here we need to understand those receptors were different from the receptors which COVID-2 is using, and COVID-2 ACE2 receptor is distributed all across almost in all organs. That's why at the end there is a multi-organ failure, because it can reach out to most of these organs. So now when it reaches into the host body, the host cell also has a transmembrane serine peptidase.
I think there has been some glitch.
Actually, there was some electricity breakdown in the medical college. She is joining from another laptop.
Okay.
It will take 1 minute only.
Ma'am, your voice is not audible, ma'am.
Yeah, can you hear now?
Yes, ma'am. It is audible now.
Sorry, I'm so sorry for the glitch. Okay.
No, ma'am. No issues, ma'am. No issues.
All right. So the coronavirus, the RBD protein is identified by the ACE2 receptor, unlike the other ones which I was saying. So ACE2 receptor is present in most of the organs. So once it enters, we must remember that the RNA strands are also recognized by the TLRs, the toll-like receptors which are present over the macrophages and on the neutrophils. So it's not just ACE2 receptors, the strands are identified. So basically there are a lot of cells which are identifying the virus and they internalize the virus and enters into the cytoplasm. Here you need to understand the virus only stays in the cytoplasm. It does not get integrated into the nucleus and it multiplies. Now, as soon as there is entry of the virus, phagocytosis, the virus then undergoes multiplication and there is cascade activation of the signaling pathway. This is mostly the mid-88 or the cyc kinases, which activates within the cell and leads to a large amount, a copious amount of cytokine formation. Now, at this stage of the pathogenesis, this is occurring at the onset of the disease within 6 to 8 days. This is the first line of defense or the innate defense mechanism where cytokines either will clear off the virus or it will lead to a cytokine storm. Now, these cytokines can also lead to virus-induced apoptosis, which is known as pyroptosis, and it can really prevent the infection from traveling from one infected cell to another. So these are the defense mechanisms which come into play. Now, at that site of mechanism where the cytokines are being released, the neutrophils, macrophages keep on getting recruited at the site. More cytokines are produced, and these are mostly the interleukin-6, the MCP1, and TNF-alpha, and gamma interferon. And at that point in time, the cytokines will build up, continue to build up. So remember that mild and moderate diseases, if your responses are good enough, that means at 6 to 8th day, the cytokines now attract the Th1 responses, the CD4, CD8 cells now come into play, and the antibody, the B cells are also getting activated. So initially the first few days you have the first line of defense, and then comes after 8 days you have the B cell activation, which starts producing antibody secreting cells. B cells undergoes clonal expansion. There's more of antibody formation, which will try to attack the virus, and by antibody dependent cellular cytotoxicity or by activating the complement cascades, it will attack the virus. And similarly, the CD4 and the CD8 in presence of cytokines will all try to prevent the virus from spreading. Now, at this point, we need to understand that the virus spontaneously, the COVID-2 spontaneous, unlikely that it will disappear spontaneously. So if you are mounting a good antibody response in mild and moderate infection, the antibodies will be useful to clear off the infection. However, in severe infection, the antibody keeps on rising. So this is the point which we need to understand. The activation of the T cells and the B cells have occurred, and now we have to understand in severe infection, what does it happen? So in severe infection, I'll give a background is when people were trying to identify the titers of the antibody at that point of time, when convalescent plasma was being given as a mode of treatment, there the titers were very high. The donors had high titers, in about 5,000, 2,000 AU per ml. However, when they did the neutralization assay, the units were very low. So this we need to understand at this point, that we were identifying the antibodies which were actually identifying different epitopes. So if you are using different platforms, different epitopes, variable epitopes, the units will definitely differ. Let's go back to the humoral responses. So if your cytokine response is very high, like in interleukin 6, and a high level of antibody, actually both are biomarkers of underlying inflammation. So in a severe infection, we must be wondering why there is so much of antibody, but still the virus clearance is poor. Probably this high titer of antibodies are having low neutralization potency. These low neutralization potency, these antibodies will continue to be secreted from the B cells with the cytokines, and after a point of time, these will cause multiple damages to the organ. So the antibody leads to an autoimmune phenomena, and this will worsen the prognosis. So this we need to understand, that sometimes if the severe cases recover, we find very high rising titers of antibodies, but that signifies that the viral load was good enough to mount this kind of an antibody. So there are certain factors we need to remember. Viral factors, the viral inoculum is directly proportionate to your antibody responses, and host factors, like if you have some genetic instability, if you have some polymorphism, or you have some immune defects, then definitely the antibody responses will not be similar to between two individuals. Now, having said that, 90% of these, so this is how it goes. The initial innate immune response, after 6 to 8 days, you will see the humoral and the T-cell immunity, which build up to clear up the infection. Let's look at these antibodies structure. So which are the antibodies that are being formed? We have both, all the antibodies actually get mounted, and you have the IgM. Let's not think that IgM is absolutely useless. Yes, it has a T-half of 5 days, whereas IgG has a half-life of 21 days. So within 21 days, the IgG antibodies will start rising. However, the potency, as I keep repeating, neutralizing potency may not be accessible by the platforms that we are using. I will come to those platforms a little later. So these, the 90%, when there is a recovery of these patients, 90% of the virus specific antibody responses usually die off. Only 20 to 30% of these antibody responses turn into long lasting plasma cells or the memory B cells. So in such patients where these long lasting plasma cells and the B cells are intact, and they have of similar higher potency, and they are able to sustain that potency, then they are able to during reinfection, they are able to combat this reinfection in a better manner. So 20 to 30% of these individuals are able to fight against these reinfection, and they it is inevitable. You cannot say that once you have developed antibodies, you cannot prevent infection. Infection will occur, but the disease severity will be less. So the IgG antibodies, once it is formed, it remains up to 3 weeks and will then usually either the longevity and is not too much. That's what the literature says. And the antibodies may remain up to 3 weeks to 3 months. Either it declines or may reach a plateau phase. So after a vaccination, what are we seeing? Similar situation will occur, but here now the antibody responses are more robust, depending upon how much the antigen has been introduced. And here you see the antibody formation. Let us remember, the antibody, when during an infection or during vaccination, it is able to identify the B cells. They are able to identify various antigenic sites. Now, each antigenic sites will have various epitopes. Now, just don't imagine that at the first instance, the antibody will be too broadened and will be able to clear off everything. It doesn't happen like that. So, as and when you acquire secondary, second time reinfection, that is the time when the B cell broadens itself. The plasma cell B cell clonal expansion occurs, plasma cells expand, will identify further more antigenic sites, and then the antibodies will be able to strike the virus even far better. So this is how this picture shows that you have a smaller responses in the first instance, secondary responses are far better. So these antibodies, the T-cell immunity literature says that it can stay up to 6 months, and about 3 months time, if you are sustaining a good neutralizing antibodies, they may stay up to 3 months. So that's why to boost that immunity, a vaccination is very important. However, 90% in US study, they have found 40 to 90% of individuals have developed good plasma cell antibodies. They have a good memory cells, memory CD4 and CD8 cells, although we do not know the duration, how long they will be surviving. They, in the previous infection, like in MERS and SARS-CoV, they remained up to 2 years. So this is now where we need to study that how long these antibodies or these memory cells remain for further for future infection, to a challenge when the challenges are there for future infection, how the body is going to react. We also need to remember that this virus multiplies in the cytoplasm and it is not integrated into the nucleus. So there is no question of reactivation. Whoever gets it, it is actually a reinfection. Now, we talked about these neutralizing antibodies. So we all now know that if it has a good potency, it will neutralize the antibody, neutralize the RBD, that is the point of entry. And so the virus will not attach to the receptors and will be inhibited or will be killed. So the various mechanisms which we understand is all about neutralizing antibodies. It should remove the virus. What about non-neutralizing antibody? So let's understand that non-neutralizing antibodies have not always been the villain. Non-neutralizing antibodies in COVID-2 have been found to be very high against hemagglutinin esterases, which is one of the component of the surface molecule of COVID-2. So that non-neutralizing antibody also plays an important role in preventing viral replication. And also it can cause lysis of the infected cell and releasing, causing the virus to lyse and prevent the infection. However, the ADE phenomena came into the minds of the scientists because of the dengue virus, which the phenomena has been very well studied. Now, non-neutralizing antibodies like in COVID-2, we have found during convalescent plasma, when they were just looking at the ELISA antibody titer only and not looking at the neutralizing potency. So at the suboptimal level of neutralizing potency, if we start giving these antibodies where they are not all, suppose 1/3 is only neutralizing, 2/3 are non-neutralizing in capacity, then this suboptimal concentration gives the virus a chance to mutate. And there they are able to escape or evade the immune mechanism, and antibody dependent enhancement can occur. Now here we need to understand in this figure that COVID-2, it is still speculated and being studied that whether it is a preventive action of non-neutralizing antibody or it is going to cause a pathogenesis. So let's understand, actually the non-neutralizing antibody, it is the Fc portion. You see the constant portion, they look for the Fc gamma receptors. Now Fc gamma receptors are present all over the B cells, macrophages, etc. They will attach to those receptors and the variable portion is looking for the virus. So once they attach to the virus, they internalize within the macrophages. So either they allow the virus to, the figure in the top shows that the virus is internalized and allows the multiplication of the virus like in the dengue virus, or it will not allow the multiplication, but it will allow activation of the cytokines. So there is an excessive cytokine response. So either ways, either it can be preventive or can lead to a pathogenesis. Let's remember that Fc gamma receptor is absent in pneumocystes and in enterocytes, where these are one of the targets or the host cells where COVID-2 enters. So we still do not know whether ADE phenomena is very popular with the COVID-2 virus or not. So this is the timing of testing. The symptoms when they occur, within 7 to 8 days, IgM rises, then it falls. Then we have the IgG response. You have the IgA response also, which gives you a mucosal immunity. However, we must understand even the transudation of the IgG antibodies, that also reaches out to the mucosa and can give you a mucosal immunity as long as the challenge for the virus is replicating. Now, culture negativity takes about 4 weeks. If you do a viral culture, they come positive till 4 weeks. And RT-PCR, it has been the maximum it can go positive till about 6 weeks. So the adaptive response, just to recapitulate, it recognizes the cell in the first instant, but later it will activate the CD8 T cells. CD8 T cells get activated in presence of cytokines and will kill the virus. NK cells, helper cells. B cells, you have to depend upon, it all depend upon, again, the activation, whether it is T independent or T dependent activation, but it depends upon the quality, whether it is able to produce enough neutralizing antibody, how much it is producing, whether it will stay, persist, what is the memory, and again, the antigenic stability. So as I've already told you, the antigenic stability depends upon how much neutralizing antibodies we are producing. We should not give an opportunity for it to escape. Now here I want to introduce a topic to understand neutralizing antibodies attached to the RBD, that is the receptor binding protein. However, the receptor binding protein is excessively glycosylated. Now this is a component which we must remember. It's a carbohydrate moiety, which although very antigenic in nature, but it prevents the antibody to recognize that site. That is why the vaccines are looking at another motive, that is the receptor interaction site. So that motive is different from the RBD. So RBD, if they are glycosylated, they will escape the antibody responses and will continue to mutate and may multiply within the body. So we need to, when we are preparing a vaccine, the conformational peptide that we are going to deliver to the host has to be very stable. If it is an unstable peptide, the antibody will not recognize the antigen and will produce useless antibodies at the time of vaccination. So the timing of the antibody response is that it rises up from 2 weeks. This is actually the result of antibody formation. Please remember, is identifying the host as seroconverted. We have seroconverted. Don't assume any other thing beyond a seroconversion. Antibody formation, let us see what are the other interpretations that we can draw. Some patients may seroconvert, some may not. And the assays which we are using, they again will identify different kind of antibodies. So some of the assays are using a combo of N protein and S protein. So those are very useful for identifying the suspected or the confirmed cases. However, if you are doing the RBD, anti-RBD titers, they are very close to the neutralizing antibodies. So these are important, and USA has said that a titer of 1 in 80 to 1 in 60 is quite good for a convalescent plasma. However, in India, 320, 1:320 is the neutralizing titer, which has been given approval for convalescent plasma. So the IgM will decline after some time, and IgG, see again this I said 3 weeks to 3 months. So that's why we are boosting the immunity, and memory cells may remain for a longer time depending upon the individual to individual. So here we need to understand an individual from one to another, there are polymorphism, the HLA typing, how the antigen is being presented from one individual to another is different. So vaccine will be one strategy where you are giving a very stable RBD or whatever is the antigen that we are providing is a conformationally stable, and so the immune responses should be until unless there are other host factors which are bringing the immune responses down, the immune responses probably should be of a similar quality in most of the population. T-cell immunity, as I said, there has been a study wherein even asymptomatic and symptomatic, they have found across that both produce a good T-cell immunity. In fact, we also have done a study. Now, this is just the the picture which we all learn as undergraduate, the primary, and this is at a vaccination, the primary and the secondary immune responses. And this picture is telling you the lower one, we need to understand when we are identifying binding antibodies, they are different from the neutralizing antibodies. So please analyze them by using appropriate platforms. So for a vaccine, we need to understand the neutralizing antibodies which are being generated from the immune from the host cells. So binding antibodies will detect only the ones which are identifying the COVID, and there are commercial kits which don't distinguish these neutralizing from non-neutralizing antibodies, of course. But however, now we have, even Mitra has recently launched the neutralization assay, which is based upon the competent viral neutralization assay. So the basic problem with this is disadvantages are that you require a BSL-3 because you have to use the live virus. However, there are these two other platforms, the CVNT and the pseudoviral based, where BSL-2 is enough, and you use a pseudotype of COVID-2 to understand this. This is one of the classical pictures of PRNT, plaque reduction neutralization test, where the middle row is showing plaque formation and neutralization. So more than 30 to 50% neutralization is supposed to be a good titer. This is again another one where live virus is used, fluorescent based, where you require a BSL-3 laboratory. And this is, I think, one of the latest ones which are using the ELISA format with a conjugate and a substrate, and this can find the neutralizing antibody titers. And this is the latest paper from India, where the patients who have recovered from COVID, you see the IgG antibody titers have been found to be very robust. So let us not get very dismayed or disheartened by this, that the antibodies are not being formed. IgG antibodies are being formed in patients who have survived the COVID infection. This is our data where we find that the memory T cells, this is still in the under process of, we have done the T and the B cells, memory cells. The T cells, which is highlighted in yellow between the cases and the control, we found a good memory cells in the patients who had severe infection. They are being generated. Now, this is again a paper which has shown that in rhesus monkey, after the development or recovery from a severe infection during a re-challenge, there was a virus clearance, was completely 100% virus clearance was possible in rhesus monkeys. So, and neutralizing antibodies in this US-based study have found that 5.7% did not develop neutralizing antibodies, whereas the titers were, most of them could develop these titers, high rising titers. Now let us understand, if we are doing a binding antibody assays, what does it mean? If you have an IgM positive, if you remember right in the beginning, ICMR had stated a guideline of antibody testing along with RT-PCR. So if you remember, this would have, and later on it was removed. So probably that would have given you a false sense of security, or we would have, if there were false positives, that also would have given rise to a lot of problem. But in the third wave, antibody testing probably will become very, very important in children. So if IgM positive and IgG negative, that means there is an active infection, you require isolation. IgM negative and IgG positive, that means it has gone the further, the infection clearance is occurring, there is a functional level of immunity you are developing or a past infection. IgM negative and IgG negative. Now either you have tested too early within less than 14 days, or you are an asymptomatic carrier, you have not mounted, the antibody responses have not come to that level. And if IgM positive, IgG positive, that means the disease is occurring and you can spread the infection. Antibodies do not define whether the person has recovered. We cannot say that, because antibodies completely recovering, people have reported even after 28 days or up to more than 4 weeks, people have have come back with symptoms of fever. So there are underlying processes, because organ damage has occurred, inflammatory cytokine markers have not come down. So we cannot just assume that why is this happening when my antibody titer is so high. Whether it's neutralizing antibodies, unless you are doing a specific assay, which I'll come to it later. Negative antibody means not, just a minute. Negative antibodies means that you are means not infected or not enough So either you are not infected, you are still susceptible, or it is not enough, as I just said, or you need to test. If you are getting fever, then test it after some time. Mild infection also, if you were COVID positive, you did not mount, that means your antibody was good enough, it cleared the virus, and your antibodies have now disappeared. Points to ponder is neutralizing antibody will guarantee immunity. Let's remember that. Let's not be, but there is this topic which someone said, Peltzman phenomena in economics. We say that, yes, I guarantee immunity, but I will not wear mask. So however, UK, US, Israel, they have done mass vaccination. So if mass immunization, then we can take that challenge and move around. But here we need 90% of the population to have immunity. Vaccine induced immunity will differ from infection induced. So if you are looking at NSN, those are infection induced. If you are looking particularly at anti-RBD, those can be infection or it can be vaccine induced. Antibody test alone should not be used for diagnosis. False negative and false positive will give you a false security. Now, this is important. The antibody test is very useful in the coming years, the coming days, to identify the multiple inflammatory syndrome in children. Why? Because the children will have a maternal antibodies in circulation, especially in less than 5 years. Please, we have to be very careful. These children will not be able to mount a good humoral response. The isotype switching is not possible in them. T-cell immunity is going to be very poor. So this inflammatory syndrome is when they mount an antibody, that is the time where they would have had a fulminant inflammation occurred in the entire system. Public health decisions, risk of infection, spread of the disease, antibody testing can be very useful. So let us come to this, summarizing the dynamics of antibody recovered from an infection. If you sustain a good amount of neutralizing titer with a good quality, yes, you'll be able to combat your reinfection. 30%, all right, virus mutant. Now, this is a hot topic these days. These make the immunity less effective. Definitely the delta mutant that we are talking about, it has occurred in the receptor binding motif where their amino acids have undergone changes. However, what I feel that the entire S protein or the if is being given as an antigenic stimulus in form of a vaccine, the antibodies will definitely identify the entire epitope, all the epitopes, and that antibody response, if is overwhelming, then and in 90% of population, then the mutants will not survive and will disappear. So once we make the virus endemic, once it becomes endemic, the fatality and the mutations will not occur because it will not get a chance for a selective pressure where half population is naive, some population is not mounting antibody. So all this is now the epidemiologists have to work upon. Cross protection to certain common COVID viruses may occur for a short duration, and still we have to work upon the data for vaccinated and unvaccinated. Herd immunity is what we are looking for. The serology testing relevance, utility, again I'm repeating, without an RT-PCR, let's not make judgment. We cannot replace RT-PCR. The usefulness in the assays with high specificity to assess population at risk, and we will do the incidence of infection in this by doing serology. Neutralizing antibody titers, this I've already covered. So what questions we cannot answer, this I took from WHO side. What percentage or group of population is immune and cannot be infected, we cannot say at the moment because we need to prospectively study the vaccinated population. How many, what titers, how long will it survive, can be reinfected, and the knowledge, by the knowledge of antibody, can be segregated in school and offices and etc. We cannot answer that. Let's go to quickly into the vaccines. We have a variety of vaccines. These are the various platforms, which are the 4 platforms which are now being currently globally used. They mount a good antibody response, and also, they are mounting both the T-cell immunity, the inactivated and the viral subunits mount the T-cell responses may be slightly compromised. However, the VLPs and the mRNA vaccines produce a very good T-cell immunity. So this is, you need to read this several times. 2 doses of vaccination works by mimicking a natural immunity. The first dose primes the memory, as I've already told you. The second dose solidifies it. After the first vaccine, the immune system needs time to generate a response. So just don't think the first antibody is going to be, first response is going to be overwhelming. It's your second response which is going to expand clonally and will identify more antigenic sites. And a larger time interval between these two probably will give you a better responses. The vaccine-induced antibodies, anti-S or anti-RBD, these are the currently are being identified as closest to the the neutralizing antibody titers, which will tell you whether you are mounting a very good antibody or not. Testing positive for any antibody other than the vaccine-induced antibody, like the N protein. If you're just doing N protein, so maybe the one which is the inactivated vaccine, there you may find N protein, but the non-vaccinated, it means that you are just resolving an infection or you have a past infection. Now, this is one line which I have written, that after certain literature and some studies which have been conducted, a 400 AU per ml units have suggested a neutralizing antibody to RBD may give you a good immune response after the vaccination studies which has been done. The escape mutants, this you are very well known that we are now concerned with the virus of concerns. These are the alpha, beta, gamma, delta. Delta, there are double mutants. These may cause reinfection, but we have to work towards it so that we don't allow it to survive. Mutants, the virus is a very simple organism. It is just looking at our cellular machinery, utilizing it to proliferate. If we don't allow this mutant to survive, then these we will be able to face these challenges with a better immune responses. So these are the ASM News latest has given that unless a vaccine is 100% effective at preventing infection, breakthrough cases are expected. Several COVID-19 vaccines have reduced efficacy towards the Delta variant. Mind you, here I want to tell you, friends, that whatever is the percentage of the variants which has been, the breakthrough infection is 0.01%, but wherever in our Maharashtra, Madhya Pradesh, Kerala, wherever the breakthrough infections have occurred, the mortality has been less. They have got the infection, but they have been able to survive. Reasons is, as I've already said, ineffective immune response, not much duration, immunity has waned out, and now deletion in, this is the N-terminal protein, which is in the S1 and the S2 region. You have the C-terminal and the N-terminal from the S2 protein, which require now scientists are working further investigation, because here it is, these lineages are now arising, further mutations, and probably in future, the SARS-CoV variants, COVID-19 vaccine studies are now being carried out to make multivalent vaccines that will include not only the current, the past original COVID-2 plus the variants. It will target multiple sites on several proteins. So we will have a better protein which will be in a conformational form, where we will be able to mount multiple responses to various antigenic sites. And this this is my last few slides. So there has been FDA and EUA authorization was given. Plenty of platforms came up and they were marketed to identify or estimate ELISA-based formats, CLIA-based and lateral flow assays to assess the binding antibodies. And we also have a lot of platforms in our country. Many people are using this, the IgM, the IgG, the combo to S1, S2. But please remember that all these tests have undergone stringent testing. The FDA has approved after following various accuracy, precision tests with panels of positives and negative tests, and only then they have received emergency authorization. Mitra is now has a wonderful platform with CVNT, which will now be in the use for not only to study disease progression, to also study immune responses in vaccinated and non-vaccinated. But here, the highlight, what I'm trying to say, is a single test when you have a positive predictive value more than 5%, you see the specificity of the test improves. But suppose your prevalence comes down to less than 1%, like in HIV, a single test will give you very high false positivity. And that false positivity will give you a false sense of security. So all these components, when we are launching a serological test, have to be kept in mind. So I thank you for this patient listening. If I've overshot the time.
No, ma'am, it's not a big deal. I should compliment you, ma'am, that you have actually highlighted with all the relevant points, including the progression of the infection and the production of antibodies. And I think most of the participants also have doubts like what is the relevance of it, and you have dealt it very efficiently with it. We will take up the questions later on. Before that, I would request Dr. Neeraj Jain sir to please bring upon his presentation and start off with that. Sir? Sir, could you unmute yourself, please, sir?
Shubhanu, can you see my screen?
Yeah, absolutely, sir.
Okay. So, Dr. Shukla has covered all the points related to this COVID-19. So there is nothing much to say for me. Only thing is, I think all of you will agree with me, this is the first time happening in the history of mankind. You can say all across the globe, people are sitting at home because of the one simple reason, this COVID-19. And till now, there is no definite treatment for this COVID-19. Today we are saying this particular treatment is effective, then we are saying no, this is not effective. We are discontinuing this treatment. No therapy is, you can say, reliably successful. Only thing is prevention. For this, what is required? One thing is corona appropriate behavior. Remain indoor, face mask, avoid physical contact, hand washing, get vaccinated. Another thing is immune protection, either through vaccine or people who are getting infected. Then the question is whether they are really protected from the reinfection or not. And the Dr. Shukla has very beautifully explained all these aspects. What is the need of the hour? We have to see what are the predictive models of immune protection, different studies which we are reading in different journals. An extensive study is required so that when we will develop vaccine in future, so they will cover all aspects related to this virus. And new virus, new mutant, question is whether it is covering all these things or not. But long-term study is required. Only then we can develop these. And she has already explained what are these neutralizing antibody, why these are useful, when these shall be tested, what are the different platforms which we are using, what are the advantage, disadvantage. And one thing is clear, if a patient is developing antibodies, then the question is whether these antibodies are really neutralizing or not. But if a patient is not developing antibody, then that means he has not developed. And this can happen in 5% of cases. And some patients, they are developing higher level of neutralizing antibodies or other antibodies. Some people are not developing that high antibody. This level of antibody which we are developing depends on disease severity and levels of inflammatory cytokines. Patients in which severity is very high or inflammatory cytokines are reaching to very high level, in those cases, antibody levels are also very high. And there is difference in the peak level and the speed of decay in the different type of presentations. But in case of mild infection and asymptomatic patients who are exposed to this COVID-19, there is lower level of seroconversion and lower level of antibody response. But that doesn't mean these patients are not protected, because this T cell response is independent of neutralizing antibody dynamics. Even if a patient has not developed antibody, the person gets some protection because of this T cell response. And what we want to achieve? We want to achieve whether the herd immunity strategy which we are planning, whether that is really viable or not. With this herd immunity, whether we will get protection or not, and with this antibody response which we are expecting with the vaccines or with the infection. So with this, we can plan booster dose to prevent large outbreaks, whether it is required after 6 months or it is required after 8 months or it is required after 12 months. And there are different type of vaccines, whether these different type of vaccines, they will require booster dose at different time interval. That we will come to know only after enough studies. Short lifespan of this SARS-CoV RBD specific antibody, but neutralizing antibody may present for years in recovered patient. Although because we have experience of only, you can say, 1.5 years. But if we compare this with our experience of SARS-CoV-1, if we compare this COVID-19 with our previous exposure of SARS, in this we found antibodies lasting for many years. And in those cases also, severity was very high. So we can say these antibody may also persist for a longer period, but what is required for this? Long-term studies are required, and that we will come to know after few years only. At present, we cannot say anything, but at present, what are the limitations we are facing, although we are working very hard? Host or environmental conditions, they affect immune response. Different ethnic group, they have different immune response in different environmental conditions, different immune response. So we cannot generalize whatever we are observing in a particular community, in a particular ethnic group, or in a particular geographical area. We cannot generalize that. And if suppose we are conducting a study in the middle age group, we cannot generalize that experience to pediatric age group or very old age group, because they have different immune profiles. Disease severity is also very important. And we have to see whether asymptomatic patients or mildly infected patients, are they really protected from the reinfection? And this neutralizing antibody also, although this is a very promising thing, but we have to study the neutralizing antibody dynamics over a longer period in different ethnic group, in different environmental condition, so that we can see what is the peak antibody level we are observing in different groups, what is the rate of waning, how frequently they are, with how much speed they are declining, and what is the longevity of this neutralizing antibodies. And we can say long-term studies are required to study reinfection among recovered patients from COVID-19. Some patient with neutralizing antibodies, some patient without neutralizing antibody. What are the chances of reinfection? And we have to assure vaccinated community about their long-term protective immunity, and also when a particular booster dose is required. And this we will come to know only after long-term study whether this level of neutralizing antibody is really corresponding to protection or not. At present, what we can say, we can only say at an individual level. In this particular case, if suppose we are finding antibody level or we are testing neutralizing antibody, in a particular case, we can say that there are some chances of protection, but we cannot generalize that statement to population. Role of this neutralizing antibody is promising, and we will come to know with experience whether it will help us in this pandemic outbreak response or not, and what is the longevity of this immunity after vaccination. Thank you very much.
Thank you, sir, for making the presentation quite crisp and what you can say, absolutely to the point, and you have actually summarized the whole essence of the this presentation also. So I really thank both Dr. Neeraj Jain and Dr. Shukla Das for making all the points available to us. Before we end, there are a couple of questions, Madam, specifically for you actually. First of all, there are many doctors who have joined in today. They are actually asking for the references which you have cited in your presentation. So it would be really nice if you can share the references for the, yeah. So
most of them are from WHO, and if you WHO site I've taken, and there are a lot of studies. I have a whole entire folder, so these references I can share it with you, and
okay.
you can, I think, or maybe I can add on a few of those references a little later. If you give me a platform, I can give all those.
Ma'am, no issues. You can forward it to me, and I will put it on the group, ma'am. No, ma'am, and there is one important question which somebody has asked, is actually about a patient. This doctor is saying that he's actually facing some kind of discordance between the neutralizing antibodies and a complete antibody test. What he's asking is that can a child be positive for neutralizing antibody with 98% inhibition, but negative for total antibodies?
No, that's what I've written. See, that is what exactly I was initially. I said the platforms in which you are finding, you are detecting. If the binding is a platform, the epitopes are different. If it is against an N protein or it is against an S protein or whatever. So neutralizing antibodies mostly is against the anti-RBD or the anti-S. So and suppose you are finding, I think it cannot be if the titer. Suppose the your ELISA binding assay, the total antibody is against a combo, that is N, S, and N. Then specifically the S would be, the component would be very less. So the total antibody, however, should be there against the N body, N and M. However, this discrepancy can be explained in two ways. Either it does not match at all, it doesn't make sense, or you are having a neutralizing antibodies, which is, if it is a FDA approved kit, then it is okay. That means the platform that are using for total antibodies, the antibodies have not risen against the N and M protein. It is against the S, and the S component is very less in that platform. So probably it is not detecting it. Whereas the neutralizing antibodies, you have used a platform where only the S protein is there. So this can be explained in one manner. So you need to see the pamphlet, the literature, what epitopes are they detecting? Or however, if suppose both the platforms are same, the binding as well as the neutralizing assays, then it should not be discordant like this. If both the assays having S antigen as the epitope, then if it is detecting the neutralizing assay, it should detect the total antibodies also. Yeah.
Ma'am, there is one peculiar question which I have also faced in the recent times. People are saying that even And that too in certain cases, it has been found that after even having both the jabs of a vaccine, okay, the antibodies have not been produced. Now people are concerned that, for example, if the neutralizing antibodies per se are absolutely not produced, should they go ahead with the vaccine of a different make?
No, no. I think it's until and unless an advisory has not been laid down. See, we have to follow the advisory of the government and the WHO, completely follow that. You can't take another kind of a vaccine. See, I already explained in my presentation that there'll be various host factors which will dampen the immune responses, or there may be some kind of a the immune response, the primary dose with the secondary dose did not mount, or the duration is not enough. So either they can, expand the duration, test it again after 3 months or after 4 months and see. If it is too early, they have detected the probability of the secondary response may not have mounted by that time. So if the duration was too less or too early, we must ask them to increase the duration and look for the antibodies again, number one. And number two, to look for another jab or another vaccine is not advisable at this point in time, because we need to understand that you have already given two doses of vaccine. The cells will take its time for antibodies to form. We need to assure ourselves that I have formed antibody. See, that's why the FDA is not approving. It is not telling us to look for these neutralizing antibodies in the vaccinees. Why are we going and giving our blood and looking for these antibodies? It is not even saying that once vaccinated, you remove your mask. You don't take those standard precautions. So besides vaccine, you have to, till the pandemic is there, pandemic has not been announced that pandemic is off. WHO is still continuing with the pandemic. So considering all these issues, vaccine, you have been vaccinated, be assured you will mount an antibody. Number two, continue with your standard precautions. And number three, pandemic is still on. You can get reinfection. So why am I not mounting? I don't keep doing antibody testing when I get a measles or my MMR or vaccine. Do I keep looking for the vaccine antibodies? We don't keep looking. Do you look for these antibodies in a child when the child is immunized? So this concept, it is okay to in an academics, it is all right. I know this participation is all the academic forum. So you may be interested in knowing the antibody levels, but I don't think that you need to, worry about it. And if there is, see, now there will be, I think, a prospective study to look for these antibody levels. A lot of studies probably will now come into in analyzing the antibody responses in India. So once they feel that probably Indian population have not mounted a good antibody response, which all is because of host factors. So then probably we may get an advisory for a next dose. But don't mix antibody vaccines as of now. I don't think so that is advisable, other than any international travel, because US says you have to get a Pfizer shot if you go and travel abroad, US. So that's a different issue. So I think, yeah.
Ma'am, a last question to both of you actually. Sir, this is for you also. Sir, in today's news, the headline has been that Delta Plus variant is the variant of concern. Now, there are loads of people who have asked the same question. Probably, we just hope that the third wave should not come. But if it comes, what would be the relevance of all these antibody testing?
We couldn't get your question. There was a disturbance in the mic.
Ma'am, I would repeat it again.
Yeah.
Ma'am, in today's news, it has been mentioned that Delta Plus variant is the next variant of concern. Yeah. So many people have asked actually that if tomorrow the third wave comes, what would be the relevance of all these available antibody testing platforms?
Yeah, so that is what I said, the antibody testing in children, that is the MISC, the multi-system inflammatory syndrome in children. It's a very big topic on its own. The guidelines are already have been laid down where the serological test will be important. and high antibody titers in these in children will probably be indicating the underlying inflammation, and we need to take rapid responses against it. So with the variant, definitely, as I said, it is a concern, worrisome issue that Delta variants. We are what I trying to say that let us not worry about that. Instead, let us do a 90% population immunity. Let's immunize everyone so that we don't allow these variants to survive. See, the virus will allow itself to undergo mutation as long as it finds a naive individual, as long as it finds an individual without any antibodies, so or subneutralizing antibodies. So if there are scientists who are working on infusion of immunoglobulins, monoclonal antibodies, which are neutralizing in nature. So these all are being worked upon. Probably that also will come into play very, the monoclonal antibodies targeting these variants. So this is the only way where these antibodies can be attacked, if at all, because it just said that Delta variant has a very high transmissibility. So those things probably are being worked upon.
Dr. Neeraj, sir, any remarks?
No, she has answered whatever is required.
Okay. I think we have got much more clarity on certain aspects, and as both of you have mentioned, that only time will tell us that what needs to be done, because a lot of things are still under, what you can say, studies, and we are still in the middle of the pandemic. There are many avenues to be explored still yet. So we just hope that we do not let off the guard so soon again, and we learn from our previous mistakes also. So before I conclude with the presentation, if you may allow me, there is a small token of appreciation. So this is a certificate of appreciation for you, sir. And we really thank you again for coming on board today and provide us with your valuable time. And there is one for ma'am also. Here is the certificate for ma'am. Ma'am, again, thank you for clarifying all the doubts for all of us today. So it has been an honor for all of us to have you today. And we look forward to have you all in the upcoming presentations also. And to all our participants, I would just like to announce that we do have our website, thetide.in, which is our annual feature of symposiums which we'll be having on in the month of December. So please stay tuned for that. And once again, thank you to Dr. Neeraj Jain. Thank you to Dr. Shukla Das for coming on board. And stay tuned for more. Thank you and have a nice evening.
Thank you.